I definitely have come to a place in my practice where there's so many ways to love and feed that baby.
Yes.
I know that in my bones, and I'm always in awe of the things families are capable of and how they show up. And so I agree, like more often than not, it goes right.
Yes.
And if it's not going right, that's a great time to reach out to somebody like us.
Welcome to the Be Well Baby podcast. I'm Dr. Emily Spaeth, founder of Be Well Baby in Portland, Oregon, and the Beyond Birth Blueprint, an online community where we support families through pregnancy, birth, postpartum, and especially life with a baby. This podcast exists because I believe families deserve better than what I am seeing in my work as a physical therapist, lactation consultant, and childbirth educator. Just a quick loving note before we dive in. Everything you hear on this podcast is for educational purposes only. It's not medical advice. Every body and every baby and every season is different, and you deserve support that is personalized to you. Let's get started. I'm so glad you're here. If you've ever Googled tongue tie, you know how quickly things can get confusing. Conflicting advice, strong opinions, and a whole lot of anxiety for families who are just trying to feed their babies. Today, I'm sitting down with someone who has spent over 2 decades untangling exactly that. Melissa Cole is an internationally board-certified lactation consultant, neonatal oral motor assessment professional, clinical herbalist, and certified perinatal mental health provider. She is the founder of Luna Lactation and Wellness in Portland, Oregon, a published researcher, international speaker, and one of the most nuanced clinicians I know in this space. I have had the privilege of taking courses from Melissa and shadowing Melissa, and I can tell you this conversation is going to give you so much clarity. We're going to get into what a tongue tie actually is, why there's so much controversy around diagnosis and treatment, what mindful aftercare might look like, and how to find providers who will actually collaborate for the best possible care for your baby. Whether you are pregnant, newly postpartum, or a clinician looking to deepen your practice, this one's for you. Let's dive in. So for anyone who is pregnant and is totally brand new to even the concept of a tongue tie, maybe they heard their neighbor's baby had a tongue tie. Let's talk about what a tongue tie is, and really let's talk about the anatomy just in plain language.
Absolutely. So we don't want to confuse a tongue tie from a frenulum, right? We have multiple frenula in the body, and let's focus on the lingual frenulum, the tongue tie. And a tie happens when there hasn't been proper apoptosis. So there's the cells that are sort of anchoring the tongue down, just like we have between fingers, toes. When the embryo is about 8 to 10 weeks in a pregnancy, that connective tissue regresses, or it should, allowing the tongue to be mobile from the floor of the mouth. And so we all have about 7 frenula in our mouths, but the tongue tie, the lingual frenulum, occurs when that connective tissue hasn't fully regressed in embryonic development like it should have to allow for proper mobility and functionality.
Do we know? So what we're talking about is the skin right below the tongue that attaches the tongue to the floor of the mouth, essentially. Do we know why apoptosis isn't happening?
Yes, so there's so many theories out there. It's like the wild, wild west. It's not as simplistic as the parent didn't take the right vitamin or this or that. So the top factors, number one, is just genetics. So 30+% of cases, if not more, are just genetically involved. So often in the family line, there is a genetic factor. We have other sort of epigenetic factors. There are things like parental, like medications, stress, certain things that can impact how an embryo is developing at critical times. There are certain things, even particular like viruses or medications out there, that can change how an embryo is developing. But genetic factors are the primary reason, and it is just not as simplistic to say if a parent takes the right thing or does this but doesn't do that, they will or will not have a tongue-tied baby. It isn't that simple.
I do think that it's common for me in my practice to see people who are pregnant. And so I'll always ask to see their tongue. and then we can talk about what it means, and then they can know postpartum what they're looking for.
Yeah.
So why does the frenulum being shorter, I guess, or not being elastic enough, the tongue tie is really that it's too tight underneath the tongue, and there's various degrees of that, right?
Correct.
But why does that matter for a baby eating?
Yeah, and it's not just the tightness, and you're right, different people have different amounts of elasticity to their tissues.
Mm-hmm.
Some people might have a very noticeable or palpable frenum, but have more mobility than someone else. So it's two things. It's the elasticity, and it's also the insertion point where
Right.
that connects on the underside of the tongue. And different babies and parents can compensate in different ways. Some have more challenges than others. And there's issues through the lifespan. So focusing just on the infant period, certainly, I mean, I think we all can agree we need the tongue to feed well. Babies
Yeah.
in particular, whether it's breast, chest, bottle scenario, however they're being fed, we need that seal, we need that momentum to create sort of a vacuum to be pulling milk well. We need strength, efficiency, stamina, so the baby's not tuckering out before they get
Yeah.
the volume of food they need in an efficient time. So there's a lot of factors. And then, of course, we can go on through the lifespan of, how we control a bolus of solid foods. Are we getting more air? Are we refluxing more? Are we having dental issues, speech issues? It goes down the lifespan. My focus is obviously on the infant period, but we do see repercussions later on.
Yeah. And I think it's important for parents who are trying to visualize this, that when Melissa says the insertion point on the tongue, if it's really far forward, that's almost like the tip of the tongue is
Yeah.
attached down, but that's not the only thing that we're looking for.
And I don't know what your listeners can see or whether they're just hearing visual, audio visual stuff. But, if they can see this little mouth model, right?
Ooh.
This would be the frenum where it inserts the base. Lots of different variations.
That's so
And so
cool.
you're right. If you think about your tongue being held down by a rubber band and you're having to just do extra work, use other muscles to do the work that your tongue cannot, some people can compensate better than others, but there's
Yeah,
usually some element of compensation. But that's why tongue tie can be so nuanced and get so controversial because they don't all look and present the same.
totally.
Everyone's body is quite unique, and that's why we really have to be good detectives.
And you can have a tongue tie, or what would be classified potentially as a grade of a tongue tie, and have no symptoms and have no difficulty feeding. And then it just gets complicated. But I
Yeah.
know, I know that you have been in this work for over 2 decades. You've
Yeah.
contributed to the research. You're constantly teaching. I've taken so many of your classes. I've, had the privilege of being able to shadow you. So before we get deeper into the clinical stuff here, I'm really curious, was treating tongue ties always a part of your practice?
Oh, well, I mean, just like my own personal self and clinical skills, like, I've grown right alongside my practice through the last
Yeah,
10 years, as I
don't we
hope
all?
everyone does. But my foundational roots, were very different. A lot of, parent-to-parent support groups, volunteer, WIC peer, lots of different locations where I wasn't always starting out in a primary clinical role. So I got to see lots of different babies and family dynamics. And as I became more of like the primary person working with a family, like in an IBCLC capacity, I think what happens is, you can't help but see families who are having feeding issues, right? That's the
Yeah.
bulk of your population, and always being curious of the why. So my awareness of tongue tie being one of the reasons feedings can go have increased challenges has always been there. And I think I've gotten better at understanding how nuanced the topic is through the years. So it is one
Yeah.
of those topics where I feel like I always was aware of it, and then how I approach it has definitely shifted through time.
Yeah, it does feel like tongue ties went from being something that nobody really talked about to
Sure.
something that everyone is talking about. There's articles, there's, people saying that tongue ties aren't real and other people saying that everyone has a tongue tie. And
Yeah.
what shifted here? Like,
Yeah.
why, for people listening who are like, yeah, I read that New York Times article.
Yeah, it's interesting because, River 20 plus years ago, you might get a little paragraph in a textbook of like, this is a tongue tie, and that was kind of it. And you're like, okay, check, I read about that. But then when you really are doing a clinical practice and frequently seeing the spectrum of anatomy, right? When you've seen hundreds of babies, thousands of babies, you
Yeah.
get to see the difference between normal and abnormal anatomy, feeding
Yeah.
challenges. And you are correct, I think, as there's been an increase, both public awareness, global awareness around the importance of human lactation and infant breastfeeding. I do feel like families want answers when it's not going well. And it is, I think, twofold. People ask, like, are we seeing more? Are they happening in the wild more? And I would say it's probably a little bit of both. And, depending on time, we can go down any tangent. But I do think that people are having an increased awareness. They're wanting answers when they're having feeding problems. And they're not just accepting like, well, we don't know why this isn't working, so good luck to you. They're wanting to know the why and have suggestions that can offer some feeding support. So I do feel like parents looking for help have been really the catalyst for increased awareness. And then clinicians are catching up slowly but surely.
Yeah. And I think just even with the internet, the education out there, there's so many people sharing their experience, which is different than when I was a kid and I had a tongue tie and, my mom didn't have any support.
Yeah.
So
Exactly. And even 20 plus years ago when there was like Yahoo chat rooms and like GoToMe's, there would be, a handful of us with different multidisciplinary lenses kind of meeting in these like Yahoo group rooms, different professionals saying, are you seeing this? What are you seeing? And then slowly but surely tongue tie related conferences. And then usually from about the late like 2010s on, we see an explosion in the literature, particularly around 2014 to 2017 in tongue tie related research. And so even the clinical awareness has been slow to increase, but it's always been multidisciplinary. It's always been from various fields showing an increased awareness.
And you were part of that research.
Yeah, and I mean, it's always been something that has been foundational to the work I do, the education I do. But we still have a long ways to go. So we've come a long way and we still have a long ways to go to really decide what is optimal best care, what are best practices.
Yeah. And I do see so many families getting a different message based on who they talk to.
Yes.
One provider will say, oh, definitely a tie. It's night and day, obvious to me. And the other provider says, tongue ties are overdiagnosed. Baby's fine.
Yes.
How do you, I imagine you, like me in our practice, are being the one who says this is likely has something to do with your baby's oral motor function. You're probably the person saying this may be related to a tongue tie after maybe numerous providers have said it's not a tie.
Yeah.
Why are things so confusing right now for families?
I know. And first of all, I think for the most part, all clinicians, providers mean well. We do just all have a very background lens. So I don't think that someone who's saying, oh, this isn't a problem, that's not a problem, is not a good provider. I think that we all have a different lens that we look through and different education around the topic. But the first thing I will do with the family is I really acknowledge it's hard when there's so many cooks in the kitchen, you're getting conflicting opinions. It's hard to know who to trust and believe. I do let families know. I mean, I really have no agenda for anyone's baby. I want to give the family quality information, give them insight so they know how much their child's frenulum is impacting feedings. Is it the only problem? Is it half the problem? What else is going on? I want them to always leave a visit having a clarity around this is what's going on and why, and here's some pathways, here's some options toward improving the situation. So I think that the best thing we can do is be a sounding board, acknowledge it is weirdly political and it makes families feel crazy, but there are people that can help them navigate the process with clarity.
Yeah. You might already have one of these, but if you don't, I have to tell you about the Aura Ring. I started using it postpartum with my second baby so I could actually see how poor my sleep quality was. It tracks heart rate variability, your sleep, your recovery, your activity level, even subtle shifts in body temperature before you notice them yourself. I really loved watching my stats change throughout my third pregnancy and then improve postpartum. And honestly, one of my favorite things is that it gives me permission to rest. As someone who struggles to slow down, that is everything. So click the link in the show notes for 10% off an Aura Ring. Or if you already have one, grab one for your partner or for your parents. They deserve rest too. What are you seeing in babies where the tongue tie is impacting feeding? What are sort of the signs that families can look for to themselves, because families are smart. They're Googling things, but sometimes they don't get the good information.
I mean, the thing with really good assessment is there is no perfect checklist because we have to be so good at differential diagnosis. So we can say tongue tie can often cause inefficiency, overcompensation with lips and jaw and other aspects of feeding fatigue, poor seal, increased air intake, low volume. They're often too tired to get enough intake. But we can also say those exact symptoms could be a multitude of other issues. So this is where a good clinician is able to help a family differentiate. Okay, 30% of the issue is this musculoskeletal tension concern, and maybe 70 of it is the tongue tie. So helping a family understand that it's usually not as simple. Sometimes it is, but it's often not as simple as you're going to go do this thing and everything is going to be okay. We want to have families have full support so they can eventually get there, meet their goals. But that is that nuanced approach to differential diagnosis is so important.
Yeah, that nuance is everything. And I think that is something that gets missed when we say it's not a tie or it is a tie.
And that's what gives it a bad name is when people are like, well, maybe it's a tie, go do the thing. And then they don't have a really good outcome. And then the diagnosis and the procedure gets a bad rap when actually it was not really well defined or handled well.
Yeah. So you talk about this mindful approach to tongue tie care. And I'm really curious for families to hear, what does that actually look like in practice?
Yeah, it's a great question. So when I think about mindfulness around our approach to tongue tie, it's a personalized approach. It's seeing the whole baby, the whole family dynamic in front of us, looking at all factors impacting feeding. It's being aware as a clinician of emerging information. Am I doing the best thing? Am I seeing that my care leads to good outcomes, or are my outcomes questionable? So it's always sort of being critical about thinking about our own practice. Am I doing the best thing? Am I approaching this the best way? So that's part of mindfulness. And like I said, that personalized approach from assessment to care plan to follow up, it will look different for every baby. It really is not a checklist issue.
Yeah. When I know that your approach to aftercare is different than some other lactation consultants. Their aftercare is a whole nother, can of worms where some providers say don't touch the wound ever. And some providers say you have to be stretching it every 4 hours for 4 weeks. So where do you kind of land in that? And how did you come to that with the background that you have and the expertise that you have?
So, I mean, as you know, I do primary research and I have done many projects through the years, and I wish that it would be an ethical project and to receive approval on randomizing kids to a certain type of aftercare or none at all and following them for 20 years and seeing what happens. But that wouldn't be a research project that would be allowed. So what people do have to understand is that a lot of times the controversy around aftercare. How do we handle this mouth after it's had a frenectomy so that it heals best? And a lot of people will say, well, we don't have evidence. We have a certain hierarchy of evidence. We need to have the right research study designs to answer the questions. We can not
Well,
everything.
and what I tell my, yeah, and what I tell my students about evidence is that evidence is actually threefold. There is the research evidence, there's your clinical expertise, and there's the family's experience. All of those are part of evidence.
Evidence, and so we definitely need to acknowledge. And there was a literature review I did, might be about 2 years ago now. Anyone can access it. It's on my website, because I wanted to start something, some foundation of what do we have in terms of evidence of aftercare, and we do have clinicians, expert clinicians around the globe saying, we noticed that we need to do something for optimal healing. Something is where people can really differ. What I have seen, even my own approach to the aftercare has morphed significantly over the last decade from what I did then to what I do now. What we're asking the mouth to do is have that tongue and the floor of the mouth not kind of heal back down together, but kind of stay open, heal from the base up. So we usually do need to do a little bit of wound care, wound management, but it needs to respect that, there's always a baby attached to the wound. And so we need to be compassionate. We need to help them have a regulated nervous system. There's always a caregiver or parent attached to the baby, so it needs to be sustainable and doable for them. And we also need to look at outcomes. I often see people doing certain variations of aftercare, have infants experience stress, more aversion, more discomfort, and then they're not getting closer to their feeding goals. Whereas my approach differs a little bit baby to baby, but I do have some basic principles I follow. I usually feel like being in the mouth, the minimal amount needed for good healing, constant follow-up, usually watching the wound visually once a week until it's done healing, and pivoting and supporting the family with where they're at. So I think it's possible. It will take a little bit of time, I think, for clinicians to come to a consensus of what good care looks like. But I have a lot of strong opinions on the topic. So I'm always happy to, I don't know, debate's the right word, discuss.
Yeah. Are you willing to share what you recommend for families that you're working with?
Of course. So typically I'll have families do something about 3 times daily. And that's different. There's some kids who need a little bit more frequency or a little less.
I know. I do find that I'm personalizing it to the family.
Of course,
And
you have to.
and I think that gets missed with new clinicians as well, that you are looking at a family who has 5 children and 3 dogs, and they're not going to be able to do everything that you're asking them to do potentially.
And that's
So
discussed even before the treatment, right?
yeah,
That's part of helping the family decide, is this the right thing for you to do right now?
totally.
I agree. But it is different family by family. In general, I have families do something about 3 times a day. It's usually a few very simple oral motor activities and then a few moments of a little bit of wound care. I acknowledge they might have received certain instructions from the provider who did the treatment, and I just let them know I have a slightly different take. They can take it or leave it. Because it is important to acknowledge different providers have different takes on the wound care. And then usually 3 times a day with some targeted little activities, a few moments, 3 times a day is what I see result in really good healing. I sometimes see too much tissue manipulation, increase
Scar tissue.
scar tissue, reattachment, stress. I'll often see a little less tissue manipulation result in better tissue healing. So I don't just do less frequency because I am nicer or something. I actually see it result in better healing. But I typically find that we're in the mouth, honestly, for 6 to 8 weeks. And it might be once a day, twice a day after a month, but I have my patients send me a little photo each week. It's just built into my medical records, and just a little reminder without send Melissa a photo, send Melissa a photo. It takes the onus off of them to worry about how it's healing.
Yeah.
They feel supported, feel like there's a safety net. And I think that helps take away some of the stress and anxiety around wondering, is it healing okay?
Yeah. And I agree. I recently had my own tongue tie released.
Yeah.
And I feel brave. I sort of, we always tell people babies are not small grown-ups.
Exactly.
It turns out grown-ups are not large babies either. And we have different healing trajectory. And for me, I agree. I think that it really did take 8 weeks for me to feel, and even still, this was done in early December. And
Yeah.
even still, I'm like, I want to stretch the tissue a
Yeah.
little bit.
Yeah.
I
Absolutely.
want that scar to open up a little bit more in my own
Oh,
mouth.
Christ. Oh, I'm so curious to hear more. I'll often find that, and this is echoed in the literature too, at about a month after procedure, the tissue in the area is about 20% its original strength, and it really can take up to a full year
Hmm.
for that tissue to have renewed strength and to be really fully
Hmm.
healed. But I usually find we're doing something for about 6 to 8 weeks minimum.
Yeah.
So that's
Yeah. And
interesting to
that's
know
the,
too. Yeah,
yeah, that's the trajectory of tissue remodeling and healing that
exactly.
can take up to 12 months. And I think families who aren't well prepared really struggle with this, with the care, with the exercises, there are things like massaging the gums and going under the tongue. And if you don't have a skilled provider who can show you how to do that without your baby screaming, it's
Exactly.
really challenging.
And it has to be without the baby screaming. I mean,
It
anytime you're
does.
doing a little bit of this oral motor work, engagement, I typically will instruct families or kind of work with them, usually after the baby's fed, they're in a good state. And so the timing of things, we don't just get into the baby's mouth and do stuff because we can. We need to
Hmm.
be, and that's another part of that mindful approach. Do I have the baby's consent? Is this an okay time? Can I get in the mouth without increasing stress, because that will not help with healing. So it is important that families have a little idea of what to expect after and that they feel really supported, because it can be pretty scary for a new parent to navigate.
Absolutely.
Yeah.
So when a baby lands in front of you, you're meeting them for the first time, what are you looking at besides the anatomy? What's that full picture that you're trying to see besides the mouth?
Yeah. Well, and typically we always have two patients, right? The parent and the baby. So we're
Yep.
always scanning everybody. I mean, we're looking at everything, right? We're looking at overall structure. Are there elements of tension or discomfort, especially post delivery, that need
Hmm.
to be acknowledged? Are there issues with tone and strength that aren't appropriate for their developmental age? Should they be doing something different based on their age and stage?
Hmm.
We're looking at the feeding overall. How is that going? I often see a lot of digestive cases, so I'm often teasing out, is this a tummy issue or reflux issue, or is this, the tongue tie or the tension? So
Hmm.
we're really looking at all aspects of the baby's body, their comfort, their intake, their output. We're checking out the parent side of things if that's a part of the feeding process. And then we're
Hmm.
putting all the pieces together and figuring out, okay, here's what's working, here's what's not working, here's the sustainable care plan, some ideas we're going to try for this week. Then we're going to
Hmm.
reevaluate, decide if we stay the course or pivot anywhere.
Hmm. That's great. I think a lot of parents listening don't really understand what should be screened.
Uh,
That if they're going to a provider who says latch looks great, you know, understanding that the screening for milestones, the screening for other things going on in the body. And you mentioned tension, which I think is such a hot topic on social media these days, all these parents come in and they're like, I think my baby has tension. And it's so much more nuanced than just a thing that you have. There's such a depth of expertise that you can go into to
oh
be
my
able to
God.
identify things like that.
I was going to say, and that's one of the things of, like, none of us can be experts in everything, but we do need to have
Right.
enough of a lens where if we're seeing a repeat issue or like a significant concern, we're like, oh, this baby definitely needs PT, OT.
Hmm.
We need to have enough knowledge to understand when the basics aren't enough and we need to have that baby be seen by someone else. So that's part of growing your clinical toolbox and being able to help a family understand maybe what other people they need on their care team. And then
Totally.
also a basic thing is, if you're working with a family and like the basics you're doing are not enough, you're not seeing change happen fast enough, or they're just plateauing and they're just never kind of getting closer to their goals,
Hmm.
and we need a different perspective, right? We're not, what is
Yeah.
that the definition of insanity? insanity, right? You keep doing the same thing, expecting a different outcome. And so
Totally.
babies usually, I mean, it's not that they all can make change super quickly, but
Mm.
if we are looking at the right things, doing the right care plan strategies, you should be getting some return on investment from that. We should be seeing
Yeah.
improvement. And if we're not, then something else needs to be examined.
Yeah. What are some things that sometimes get mistaken for a tongue tie? Like the baby comes to you and says, my pediatrician has a tongue tie, and you look at it and you're like, I don't think it's the tongue tie.
That is
It's,
a lot of my caseload. So people obviously
Mm.
know that that's something I work with a lot. They often come in either thinking, my baby has a tongue tie, I just want you to check it out, refer me, or so that there's a lot of cases where the family just assumes the baby has a tongue tie and they're surprised to find it's either something else or it's something in conjunction with. So many times it's digestive. The baby's clamping and pulling and tugging because they have reflux or because they're not pooping but once a week, or, we can insert any GI issues. So tummy stuff. Sometimes there are cardiorespiratory factors. If a baby is working hard to coordinate suck, swallow, breathe, they can act like a tongue-tied baby simply because they are doing some increased work or they're needing some respiratory breaks. So we'll see, tongue tie look like other medical issues in disguise. So tongue stuff, other medical issues, tension and strength factors, right? Babies who are maybe dealing with other aspects of developmental issues, or even I would say sensory type issues. Their experience in the world can be different than maybe another baby. They often can just feed a little differently and need some support. So yeah, there's a lot of lenses where we're looking at these sweet things, and they're all doing the best they can. They're all awesome and amazing, and we just want to help families get some solutions they know how to proceed.
Yeah. Yeah. And I think that's something that I talk about a lot is your scope of competence versus your scope of practice. You know,
Good.
it can be within your scope of practice to assess something, but
So I like
it doesn't necessarily mean it's within your scope of competence yet. And if it doesn't feel like it is, go and learn, but be very willing to refer out.
And I think this is where families also feel stuck, especially if they're like, well, I've already seen 3 PTs. I've seen 4 lactation consultants.
I know.
And I think that that's the challenge, is because we can agree that spectrum, that scope of competence will vary clinician by clinician. And I would also just encourage a family, if they've seen somebody, even the most wonderful person in the world, but they don't feel like they're getting answers or making progress in a way that fits their family's needs, they may want to explore seeing someone else.
Yeah.
Right? You would go back to a provider again and again and again if you didn't feel like your problems were being fixed.
Yeah. And I think there's this misunderstanding of the procedure where you hear all of these amazing stories of people saying, oh, they clipped the tongue tie and then my baby breastfed happily for 15 minutes and we lived happily ever after. So what do you see in your practice that really needs to happen before the tie release and after to make it successful?
Yeah. So you do have to have a good idea of how much of the problem is the tongue tie. Is it really, because sometimes there are cases like that. That's the only thing that's an issue. And we do treatment and then it does get better quickly. So those are the cases where it's pretty straightforward. So before treatment happens, we need to have an understanding of like how much of the problem is the tie. Is it everything and that's the only thing we need to deal with? Or are there tension or strength issues or GI issues or other issues that we need to factor in so that we get some forward progress in resolving those issues, and then decide, is now the best time for procedure? Do we need to do a few other things first? Maybe a better time is to try some care strategies for a couple of weeks before scheduling. So there are definitely babies who need some more prep time. There are some kids who don't. And that's what a good clinician is going to help a family decide of, is this really something that needs to be surgically addressed? And if so, do we need to do any other preparatory work so we get the best outcome? Because I would never refer a family saying like, I don't know, just go get a surgery, cross your fingers, come back and see me. I don't know. That's not, to me, acceptable and not an acceptable referral or care plan.
Yeah. Yeah. I love that.
So also, a lot of people have a very regimented like prep. A lot of people think you need to do so many things before a frenectomy, and they also have this almost pre-frenectomy checklist, and I think that is not true too. So I think every case is individual and needs a personalized approach. So
I totally agree. And I think anytime you have a protocol, you
yes.
gotta look at it carefully because it's so easy to say like, I have the best protocol. It's here and it just tells you exactly what to do. And then it's like a pill, you know, you're done. It's
I
magic.
have a visceral reaction to the word protocol. Like, oh, I don't know how I feel about that, but yes. Yeah.
Yeah, yeah. And I think parents want that though, right?
Yeah.
You know, any parent who's coming to you who says, wow, your protocol, quote, unquote, is different than the one that the surgeon gave me. And so you're like, you know, you have to look at the baby, you have to look at the wound. Every time you're in there,
Yep.
you as a parent are actually going to become a mini expert in your own personal baby's tongue tie.
Yep. Absolutely. Such a great point.
Yeah. I want to go backwards.
Yeah.
You mentioned GI and digestive discomfort being pretty common. What are some of the most common things that you see that babies are struggling with in their
Oh my
bellies?
gosh, definitely. So, I mean, from the start, I mean, we can have bowel movement issues, whether it is constantly having bowel movements or not going for days and days and weeks on end.
I know the
So,
babies, the
yeah,
parents who come to me and say, my,
I know.
like every diaper has poop in it.
Yep. Constant elimination, like they're rapidly trying to eliminate something, usually indicates there's some discomfort. I mean, frequent bowel movements for newborns, that's normal. So there is that spectrum.
Right.
Too much, not enough, just right. So I'll often see bowel movement, regularity and bowel motility issues be a factor. Reflux, which is also very nuanced. There's so many things that factor into reflux, from anatomy to food intolerances to swallowing patterns. So I see a lot of babies that are very uncomfortable. And these are often the kids that need a lot of mood micromanagement, right? They always have to be contact nap, holding up, bouncing. The parents are constantly needing to help this baby feel better. It's very different than just a baby that had a little fussy period, you know, from 6 to 9 p.m. That it's just a very different baby, and parents who are really kind of beside themselves with a very uncomfortable baby. That's often digestive, not always. So a lot of times it's gas, it's bowel movement, motility, frequency, refluxy stuff. Sometimes we'll see food protein intolerances or other issues where baby is reactive. So that's, again, you know, just like tongue tie, it takes kind of a nuanced perspective to kind of tease out, what do we think the root of this is? What do we want to try for a week or so and then reevaluate?
And what are you seeing are the biggest, you mentioned milk protein intolerance, but what else are you seeing as the biggest culprits for that GI discomfort?
I mean, that's so loaded, because I also feel that it's not just a baby issue, right? And we have sort of a epidemic of GI issues. I think I heard on NPR like 60+% of like US adults have some kind of IBD, IBS. Like that's more than
Yeah.
half of our population dealing with a we don't know what's wrong with your gut, but something's wrong diagnosis. And
Yeah.
so the babies, you know, parents' digestion is echo, right? Like in their infant's digestion. So I think we have predisposition based on family history, kind of again going back to that genetic debate and embryological time. So that's often, you know, family trend. But I also think that it's not that every baby will always have these issues. They are in a sensitive time period where they're actually meant to have a quote unquote leaky gut, because they are developing their immune system. Things are supposed to be passing through. So we have the anatomy of the digestive tract. We have things that can increase hypersensitivity. So again, you know, I don't want to think it's as simplistic as just telling a parent to eat this or don't eat that.
Yeah.
And I would never want to deprive a, you know, lactating parent or make a parent's life harder. So I always try to be a good detective and make a realistic suggestion. I don't recommend things like the old school, you know, elimination diets, like eat lamb and rice for a month and call me later. Like we want to be good detectives and help families with a plan that works for them based on their unique needs. Yeah.
I know that you have a background in herbalism. You have so many courses that any IBCLCs listening who are interested in should look into Melissa Cole's
Oh, thank
herbal courses. Do you see any specific herbs that the lactating parent can take help those GI issues, or is it really like case by case?
you. Well, and thank you for mentioning that. I mean, that that is I have a master's degree in therapeutic herbalism, and so I feel very comfortable talking to families who are interested. Not every family I work with
Mhm.
is interested in anything holistic, but if they are, I definitely feel like it adds depth to my toolbox, things that I could
Mhm.
suggest, whether it is, a particular probiotic for the parent or the baby, or a particular herbal, drop or remedy is something that could be given to the baby directly, depending on age and stage and need. Through
Mhm.
the parent, sometimes, I mean, doing things through the parent doesn't always translate to like a relative infant dose that will
Yeah.
help the baby. But yes, those are definitely things that we talk about. So it could be things like probiotics for parent
Mhm.
infant, digestive enzymes for the parent. It could be something like herbs that are, say, in gripe water have evidence base. I mean, I can pull out several studies looking at particular herbal formulations that support
Mhm.
infant digestive comfort. So I think
Mhm.
parents should know if they are coping with an uncomfortable baby, there are things to consider, but I will also make a big disclaimer: just because something is natural doesn't mean it's safe or that it's appropriate for your baby.
Mhm.
So if it's something that's very new information for you, do talk to somebody where they have that expertise to share so you know that you're safe, your baby's safe.
Yeah.
Um,
Yeah, I always tell people just because it's a plant,
yeah,
it's still medicine.
yeah, yes. Yeah, and so we want to respect that. They're definitely, again, going back to that mindful approach. We want to
Mhm.
personalize it. And there are lots of over-the-counter things parents can buy without any, clinician input whatsoever. There's gripe waters and probiotics and tummy tonics. And in general, a lot of the over-the-counter things, for the most part, are not going to cause a ton of harm for most babies. But I'd also say if you have tried some things and you're still struggling, it might be time for a deeper dive or a more personalized approach.
Yeah. If your baby ever needs a pacifier, and not all babies do, the one I want in your world is the Ninny. It is the only pacifier designed to actually mimic the shape and function of the breast. It's softer at the base, like an areola, and firmer at the tip, like a nipple. And that shape supports healthy oral development instead of interfering with it. What I love is that babies can't just passively hold it in their mouth. It's counterintuitive. Parents get frustrated. But babies have to actually work hard. I call it my workout pacifier. And tongue strength and mobility matters for feeding. It matters for regulation and for long-term oral function. Plus, babies don't tend to get dependent on this pacifier the way that they do with traditional pacifiers, or especially pacifiers with a bulb on the end. It just sits in their high palate and hangs out. So if you're pregnant, postpartum, or buying for someone you love, you can grab one through the link in our show notes or use the code BEWELLBABY for 10% off. BEWELLBABY for 10% off at checkout. How do you think about the team around this baby when you're dealing with a tongue tie, for example? Who else do you feel like needs to be involved? It may be different based on your scope of competence, right? Like, I'm not an herbalist. I'm not going to necessarily be
Yeah.
going deep into the herbs. And if someone is asking me about that, I'm going to bring in someone who knows more than I do.
Mhm.
So I'm just curious what you're thinking about.
Yeah. Again, there's never that checklist protocol, but
Of course.
if I see a baby where they don't seem to be doing physical activities or meeting developmental milestones, even though we've worked on some basics, I might be deciding, do they need to see a good pediatric occupational therapist? Do they need to see a physical therapist? If we're seeing a lot of musculoskeletal tension or compromised strength issues, do we need to connect them with some form of manual therapy that resonates with them, whether that's physical therapy, a particular, specialized chiropractor, depends on what the family's comfortable with, what they can access. And
Mm-hmm.
so luckily, I mean, our community is lucky. We have lots of different resources. That's not true for every community.
Yeah, that's true.
So who's on my team depends on who the baby needs. And a lot of times, besides just referring for a procedure, I might be referring for manual therapy, for developmental support if there are concerns there. There are lots of cases where a family thinks maybe it's just a tongue tie, and I'm feeling much more concerned that there may be other like neurological issues, genetic issues, and so there's sometimes hard conversations, but then that would be a discussion and a referral to whether it's their pediatrician or to a specialist that they need.
Yeah.
So it's going to be different, but I think that's where we have to sometimes have hard conversations with families that
Yeah.
this feeding issue isn't just a feeding issue. It's an indicator that something else might need to be checked out.
Yeah, I have found with a sweaty baby, for example, who I'm really concerned about cardiopulmonary function. Those are tough conversations, but I am always so
Yeah.
happy to be wrong.
Yeah,
I'm so happy to send you to somewhere to maybe freak you out a little bit, but then be wrong because my eye is acutely trained for this and I know when I'm seeing something typical. So,
and that comes from the decades of experience, the years of experience. Because sometimes when I do have somebody observe or shadow or mentor, and they're like, "How can you figure things out so quickly?" I'm like, "You want to know all the horror stories or things that I did wrong back in the day?" Like we definitely learn and grow, and like I will always be learning and growing. But it really does take the tincture of time and seeing thousands of babies to see the
yeah,
spectrum for things that are nuanced to catch your eye.
yeah.
And to
I do
spend
want
more time with them, not just like a 15-minute well baby, but I'm seeing them, right, start to finish probably for about an hour. You're not going to just see them get sweaty in 5 minutes, right? They might
right.
need to work towards getting sweaty and why. Yeah.
Yeah. And I do want to talk about what this is like for parents. I
Yeah.
know that you have the
Yeah.
perinatal mental
Yeah.
health
Through
certification.
PMH.
So what do you see this experience doing to the lactating person, to the family, and, the conflicting advice, the pressure, the uncertainty, the aftercare even? Let's
I'm
talk
so
about
glad you
the
brought that up.
family's experience.
Yeah. I mean, there's never just symptoms in a vacuum or a baby with a problem we're going to fix. We always need to acknowledge that there's a caregiver, parent, a family dynamic, and check in. And I think that's also something we get better over time of reading between the lines, seeing things that the parent is expressing that maybe they're not actually saying out loud and checking in on them. A lot of times families dealing with significant feeding issues, are dealing with a ton of stress, whether they already came with anxiety, this usually adds a layer, whether it's situational or generalized. So I do see a lot of perinatal mood concerns in the whole family. I mean, not just one parent, but it's often in both if it's a two-parent household. So we want to check in, and I think it's okay to really just check in and say, hey, I'm a little worried about you. This is such a tough situation. Are the days getting harder? Are they getting easier?
Yeah.
Because a lot of these situations aren't a quick fix. We know families might be in it for the long haul, and letting them know, you know, our community has so many resources. Are you already tapped into therapeutic resources? Do you need some support? And helping families get resourced, because sometimes you're the first one to check in. It's like, I'm worried about you. How are you doing today? Yeah.
Yeah. And then sometimes just that question is the bucket of tears, because you're the first person to ask.
Yeah. Yeah.
Yeah.
Yeah.
Yeah.
So
That's
it's
great.
always good. Any clinician that's working with a family, whether you're doula, midwife, pediatrician, anyone that's working with a family, particularly in this perinatal period, should have some awareness of mental health. Even if you're not doing some validated tool screening, checking in, and that should definitely be something. I always encourage extra trainings. If it's something you feel uncertain or you're thinking, well, that's somebody else's job, all of us should be all of our jobs to check
Yeah.
in on that family.
Yeah, yeah. And I think there's so many, wherever you are in the world, there are resources for postpartum parents, be it online. There's so many resources out there. And even just, if you have your own practice and you're listening to this, you can, with HIPAA consent and everything, connect people who are kind of in the same boat and have them be a support for each other. And we really have this opportunity to build a village. So,
Yeah, and know what your community resources are, right? To know what you have access to, maybe what you need to build up. Yeah, certainly national or global organizations exist. Lots of things have warm lines or hotlines that parents can access. And I think it's also appropriate to ask, what type of therapeutic support they feel like they could benefit from most. Do they want to talk to someone? Are they not a talker? Are they not into groups? Do they want to work one-on-one? Are they interested in exploring anything from an herbal option to a medication option? I mean, I think it's good to acknowledge there are many forms of support and it doesn't have to look the same way. And sometimes it's even the acknowledging, like, maybe right now is not time to unpack the suitcase. Maybe we've got to keep it packed up for a little bit longer. But I want to plant the seed that when you feel ready to unpack it, there are support strategies for you.
yeah, I love that. That's a great analogy.
Sometimes
And I think families can relate to that.
Yeah. If you're in survival mode, you're like, I cannot do another darn appointment this week.
Yeah.
Just acknowledging you see them, you hear them, and you'll be there.
Yeah. What do you think would help a family who's starting to navigate this, who's maybe listening to this thinking, well, I'm not in Portland, Oregon, so I can't work with these people. Although I don't know about you, but we see people virtually.
Yeah. Same.
It's much harder to do the oral motor assessment virtually, right? And sometimes it's really nice to have somebody work on your baby specifically. And if your baby needs body work, you need a person there with you. However, you may not have access to us.
Yeah.
So if you are talking to a family and having them, come up with questions to find a provider who's going to kind of speak this language and actually be really collaborative and won't, I don't know, push their agenda or, think that they're always right. I think that's a red flag. It's a huge red flag. So just questions that someone might think of when they're trying to find the right provider to support them through this.
It's such a good question. And because I do present and teach in lots of different areas, like I do see geographical areas where the resources are really limited. I was presenting in Alaska last year, and, there are people in very isolated, remote areas that, there's not even a specialist to be found. So we do need to be practical and think about that. So one of the great things, I mean, at least from an IBCLC standpoint, is that we can actually practice globally. Like I can see, I'm not bound to just practicing in my state, so I can see families anywhere virtually. So that's true for IBCLCs unless they're billing insurance under a different license or something. So they're virtual options. In terms of in person, I wish there was a general, like, find a provider that I could just say on this podcast and people could go onto it. I will say that ICAP, the International Consortium of Ankylophrenia Professionals, ICAP, while I can't vet every person out, what I will say is that most people that are part of that organization have a vetted interest in tongue-tie related care. Okay, I cannot say how well people collaborate or what agendas they have, but I can say generally people that are part of ICAP have a vetted interest in tongue tie and in continuing education around that. In terms of feeding specific support, gosh, I mean, you can always do like find a lactation consultant or find an SLP or find something, but that in and of itself isn't a good screening tool. I mean, I do think that a lot of times people will reach out via email or something to me and say, hey, I live here, and I can give them suggestions. Can ask people, like, don't be afraid.
Ask your friends.
We're real people, we reply. And then that is one of the benefits of some of the social media platforms, is that I do see parents helping other parents connect with resources and get to places. So there's certainly specific groups, whether it's tongue tie or GI stuff, or there's certain groups online where I do feel like parents often really empower each other to see professionals that have a deep interest in the topic
Yeah.
they're looking for. Do you have
Yeah.
any particular resources you like,
I
Emily?
think I think ICAP is a great resource, but I also just encourage people to like poke with
Yeah.
questions.
Yeah.
Just say, who else, like what I asked you, who else is on the team? If we're going to
Yeah.
be moving forward with this, who else might you consider referring us to if you
Yeah.
see something else going on with the baby?
Yep.
I think it's a red flag if they say, no one, I'm all you need.
Yeah, I have an ongoing resource list
Yeah.
on my website that is
Yep.
a mile long, but yeah,
Mhm.
there should be lots and
Yeah.
lots.
I also think, what would you do if we're not reaching my goals? What if my goal is exclusive chest feeding and I'm not doing that within 4 weeks?
Yeah.
And I tend to just give really specific situations that I would really be sad in
Yeah.
and I know that I would need support. And then you can see what they do. If they get defensive, there's your red flag.
Yeah. Specific goals like that are hard because there are goals
I know.
that
Yeah.
sometimes are not going to be realistic. Like,
Yeah.
let's just be frank. Sometimes a parent might have this be their dream feeding scenario, and we know whatever's happening on the parent side, the infant side, that will not happen most likely. So I think that as a clinician, I mean, it's hard stuff, but I feel like we do owe people the benefit of our experience, and we can often say, I hear this is your goal. Let's see this week how much we can ask your body to do or your baby to do, and let's reevaluate at the end of this week.
Yeah.
And sometimes they might ask a very hard question like, do you think this will ever be possible?
Totally.
And sometimes we need to say, there are lots of ways to love and feed your baby. I think that this might be possible. This thing over here might be not a very possible thing in the timeline we're working with or ever. So we hold space, we have hard conversations, and I think that it's hard to watch a family kind of receive difficult information, but
Absolutely.
also we're going to be one of the safest spaces to do that.
And if
So,
we're saying, you're getting the question. So as a provider, you're getting that tough question that the family's like, well, Emily said I should ask really tough questions. So I'm going to ask a tough question.
yeah,
Giving that kind of answer, like you just said, of in my experience, I'm not sure. And I wish I had a crystal ball that could tell us what was going to happen, but I don't. And I would love us to see if this week we could go up to this point, and being able to navigate those questions with ease and with honesty, because it's so easy to want to give a person what they're asking for, right? You want to say, yes, your goals are attainable. But that's not always true. And you don't know. So you can't promise something, that you're not.
no guarantees. But I
Yeah.
do think that we can have enough insight to say, this may be possible, or I'm concerned that this may not be possible in this time frame. I think we can have honest conversations so we aren't giving false hope for a
Yeah.
particular situation. And I think where that comes from, the basis of acceptance of a situation comes from like, can we give them clarity around what the root cause of the problem is? If I can say, your baby's feeding issue, it's not just a matter of a simple tie fix. It looks like there's some other like genetic factors going into their feeding ability, or whatever the scenario is. I think when a family has a stronger understanding of the root cause of a problem, then we can operate from a place of understanding and not just, well, we don't know why this problem exists. So I think that's part of it, is being able to help identify the root cause and provide anticipatory guidance around what that looks like moving forward.
Yeah. So if a family is listening to this, they're still pregnant, what do you want them to know about this? Just so
No,
that they're not blindsided.
I was. If you are a pregnant person or a newly delivered person just listening, I actually want to take away the fear aspect, because to be honest, most people seeing me, that's not the majority, right? It's a niche group having particular issues. So what I really want to say to people that are pregnant or just having a newborn is that a lot of times things work out fine and a little support is enough. We're talking about very particular cases or challenges that are difficult, but more often than not, parents and babies are quite resilient and awesome and can navigate challenges with support. So I would want people to not assume they will be dealing with, significant issues. But it is good to have a sense of who might your team be. Do you have a feeding support person, a lactation consultant? Do you have somebody or a few names so that if you find yourself in a position of difficulty, you can turn to someone? We can't plan for every scenario, whether it's a pregnancy, labor delivery issue, or feeding issue, but we can maybe be resourced with kind of knowing who could we turn to if needed. And I don't know if you know Kestrel Gates. She has a postpartum workbook.
I do.
Yes, I love her postpartum workbook because it helps families in the state of pregnancy kind of plan for this of like, hey, here's our roadmap if these issues arise. What's our support plan? What's our team like? So I like the idea of just cultivating resources. You can't plan for everything that may or may not happen.
Yeah.
So thinking just about kind of like your resources, lining those up.
I agree. I also think just one prenatal lactation visit can make you feel so comfortable with your IBCLC. And then you've got them on speed dial. You already met them. And so if there are any issues, you're not going to hesitate and you'll get help. You won't have to wait for the pediatrician to say, well, let's just see how it goes. You'll be able to say, this isn't right. I learned about this prenatally and I know who to call.
Yeah. And I see so many people, they do like 6-week birth classes. I'm like, I hope you're feeding longer than you're in labor and spending a little pocket of time on feeding prep, whatever that looks like to you as a family.
Yeah, I agree.
I think that would be a wonderful way to spend an hour at least before delivering. Yeah. Yeah. Right.
Yeah. There are 6 hours of prenatal lactation education in our online program. And I still think it's not enough. There's so many things that you can learn about, and it still just scratches the surface of what it is to be postpartum with a newborn. It's so beautiful and fun. And Melissa's right. Most of the time, it goes really well. And we're just here for the times that it doesn't.
Exactly.
And to let you know that it is not normal for it to not go well,
Exactly.
and you don't have to live through that. You can seek help.
Yeah. Yeah. I think if there's one lesson in over 20 years of practice, it would be that I am so humble, especially now, so humble in watching families navigate different things, right? The joys, the hardships, feeding challenges, that I definitely have come to a place in my practice where there's so many ways to love and feed that baby. I know that in my bones, and I'm always in awe of the things families are capable of and how they show up. And so I agree, like more often than not, it goes right. And if it's not going right, that's a great time to reach out to somebody like us.
Yeah, exactly. Well, Melissa, thank you so much. This has been just a delight.
I wish we could hang out all the time. Perfect. Well, have a good rest of your day, and hopefully our paths will cross again soon, okay?
I know they will.
Yeah. Sounds good, Emily. Thank you.
Bye.
Bye-bye.
That's a wrap on today's episode. If today's conversation resonated with you, the biggest takeaway I hope you walk away with is this. You do not just have to accept that feeding your baby is hard. There are providers out there who will look at the entire picture, your baby, your body, your family history, and help you find real answers. If you want to learn more about Melissa's work or access any of her resources, you can find her at Luna Lactation and Wellness, and you can find all of those links below in the show notes. And if you're looking for online support, the Beyond Birth Blueprint is such an incredible resource, and I want all of you to have access to this type of information. If this episode helped you, please share it with a pregnant friend who may not even know that this could be a possibility, with a new parent who might be struggling with feeding, but all of the providers who saw her baby said there wasn't a tie, or a provider that you think might benefit from understanding the nuance. This is how we get good information into the hands of the families who need it most. Please share, because you deserve to thrive, not just survive. Until next time. Audio and music production by the amazing Peter Gary, with Lillian Ewert managing all scheduling and operations of Be Well Baby, including this podcast. Thank you both for making this happen. New episodes drop every Wednesday, and I'd love for you to follow us on Instagram at BeWellBabyPDX or visit BeWellBaby.org to book a time to chat with us. And if this episode helped you, please send it to someone who's pregnant, postpartum, or someone in your life who wants to support you better. No one should have to do this alone. Welcome to Be Well Baby. You're in the right place.